Ah, no muy, mira, si quieres la pongo, recibí una tuya, aquí acá, esta.
Sí, nomás es que cambié, por ejemplo, porque tú pones ARPSP, entonces yo cambié todo a PSARP.
Perfecto, no te preocupes.
Y después había algo de MRI que también cambié.
Ok,
Son pequeñas cosas.
tú mandas.
Perfecto. Entonces, I think we can go to the main session.
Okay, just a second.
Es rey. Quería poner el micrófono, pero a ver si funciona un poco mejor y se oye más limpio. Bye, bye. Ah. Right, I'm gonna change my mic. Let me see it's working.
Okay,
Can you hear me?
yes,
Okay.
perfect. And we'll go live in just 1 second. There's one thing I have to finish doing. So we're now live in the session.
Después de presentar a Andrea, voy a apagar mi cámara porque me voy a trasladar al INP, ¿sí?
Por
Voy escuchando.
supuesto. Está
Gracias.
bien. Good morning. Welcome to our International Colorectal Web meeting. So far, we have detected pediatric surgeons from Mexico, Spain, Slovakia, Ukraine, and Yemen. So if I have not mentioned your country, please type in the chat and we will acknowledge at the end of the meeting. So it's my pleasure to welcome Dr. Carla Santos, who is presenting from Instituto Nacional de Pediatría in Mexico. Welcome. We cannot hear you.
Good morning. Today I will present a 5-year-old boy with anorectal malformations with rectoperineal fistula. At the referring institution, he underwent anoplasty at birth, but the anus was mislocated outside the muscular complex, and he had severe constipation. And for that, they did a diverting colostomy followed by PSARP with rectal tapering and a program of rectal dilations until reaching a size 15 Hegar. Then he had a colostomy closure. The patient persists with severe constipation, and nausea, and severe abdominal pain when taking Senna or when he had rectal enemas. Besides that, it didn't empty the colon and persist with abdominal discomfort for hours. This is the initial image before the bowel management program. Initially, we did a fecal disinfection with rectal enemas with phosphate and sodium citrate every 12 hours with 3 doses. Because he didn't tolerate regular volume enemas with nausea and severe abdominal pain, we tried with rectal enemas with a volume 400 milliliters of saline solution without any irritants and wasn't tolerated. We tried with rectal enemas with a lower amount of saline solution and small amounts of irritants. The pain decreased, but we could not achieve glycine. We decided to increase the saline solutions only 50 milliliters more, but it wasn't tolerated. The X-ray, This is the initial X-ray of the contrast enema, and we can see the megarectum, megasigmoid, and after we observe the colon with austrations. This image shows that the megarectum and megasigmoid and the sigmoid is not lean. Another two images where you can see the megasigmoid. We perform a sigmoidectomy, preoperative X-ray after bowel preparation with oral PEG and rectal irrigation because the enemas were not tolerated. This drawing shows the anterior-posterior projection of the megasigmoid, and the line blue is the peritoneal reflection. This drawing shows the lateral projection. In yellow, you can see the bladder and how we put the stapler for reduction of diameter for the anastomosis in the pelvis. We observe always the posterior wall because the arterial and venous irrigation comes from here. In this image, you can see that the anastomosis was done to the posterior wall with two lines of suture. The first layer was total thickness and the second seromuscular. This is the final aspect of the anastomosis. The feet of the patients, they're towards here. Here. And you can see the line that hides behind this retractor in the anterior wall of the rectum. The postoperative course was satisfactory. We didn't know lymph drains and start feeding of the third postoperative day after presentation fecal evacuation. For a week, we gave him osmotic laxative, and then in the follow-up visit, we switched to a stimulate laxative. Currently, he is 1 month after surgery and receives 70.2 milligrams of Senna every day. He had 1 fecal evacuation, and this is the X-ray after fecal evacuation. Thank you.
Thank you, Dr. Santos. Does the audience have any questions? I think this case emphasizes how important it is to follow up on patients, because the type of constipation that we see in anorectal malformation is a severe constipation that has to be managed aggressively. In this case, again, we don't argue with success. It's very good that the patient responded well, but I personally try to be very conservative with surgery. But I think based on the contrast enema, this is one of the cases that we should consider surgery, especially if the patient does not respond either to a good bowel management with laxatives or enemas. Dr. Peña, Dr. De La Torre, do you want to comment?
Yeah. Thank you for that presentation, Carla, for the diagrams and that illustrated very well what you did. And in this case also illustrates the fact that when we operate a patient with anorectal malformation, we are obligated to guarantee that the patient is emptying the colon every day completely. So that requires follow-up and also requires for a period of 1 or 2 weeks to determine the amount of laxative that is good for that patient, and then follow up, because this problem of constipation is treacherous. It's when we think that they are doing well, the patient disappears for 3 months and comes back fecally impacted. So that I perform similar operations to the one that you did and follow the patients. And it's very important to tell the family that the patient is not cured. The patient with the operation will facilitate the management of the patient, but doesn't cure, because the rectum that was left there is a piece of bowel that has an abnormal motility, and that's why the patient needs again to determine the new amount of laxative and follow up. In other words, what is good amount of laxative today may not be the same 2 months from now. Don't lose the patients, because then we have unhappy surprises when they disappear. Congratulations again. No question that the patient is going to be have much better quality of life.
Dr. De La Torre, do you want to comment?
Yes, thank you, Andrea. Just want to remind everyone that if you have a patient with anorectal malformation, usually patients that we already know that they will be constipated, like rectoperineal fistula, rectovestibular fistula, you need to treat this patient timely, very early, before you expect to have the patient come when he's 2 to 3 years on diapers, because he's not doesn't have bowel control because of constipation, and he's taking polyethylene glycol, whatever. You need to treat the constipation very, very early. So once you close the colostomy, if the patient has a colostomy, you need to follow the patient 2-3 weeks after with an X-ray, and then follow the patient every month or every 3 months, because you need to think that the patient is constipated. So you are going to prevent these problems like Carla already showed you in the presentation. So please try to do the timely and aggressive treatment of constipation in patients with anorectal malformation to prevent future surgeries like this one or any other one. Thank you, Andrea.
Perfect. Carla, if you can stop sharing your presentation, we'll now have Dr. Maria Sornosa presenting from Puebla, Mexico. Welcome, Dr. Sornosa.
No se oye, yeah.
Can you see my presentation? Okay.
Perfectly. Yep.
I want to share with you the case of a patient, 65 years old. He was operated on 1957 because an anorectal malformation with partial fecal incontinence as a functional result. And he had 3 children. The older daughter was healthy. The younger son was constipated, and the middle daughter has an anorectal malformation with 6 previous surgery in her country, 3 PSARPs. She presented a rectovaginal fistula as a sequela that was corrected by Dr. Peña in 1995 with a new PSARP. A sacral defect was found, and a benign teratoma was resected in the surgery. Here, you can see the sacral defect of the middle daughter. And here, you can see the sacral defect of the youngest son. Our patient had a tomography in 1995, and you can see a 4 centimeters presacral mass. Which is the most frequent presacral tumor? Teratoma, anterior myelomeningocele, lipoma, intestinal duplication, or dermoid tumor. Everyone can vote. Teratoma, okay. The family decided to operate on the younger son in 2001 because he also had an anorectal malformation. A primary PSAR was performed, a mature kyst teratoma was resected, and an anterior meningocele was corrected. The decision to operate on the youngest son was that in 1999, our patient's nephew presented painless swelling of the abdomen. Polycystic liver disease was diagnosed, but 1 year later, he began with pelvic pain. A lytic pelvic bone lesion was found, and the biopsy revealed a neuroendocrine tumor. A extended study showed lesions in pancreas, kidney, mesentery lymph nodes, bone marrow, and hepatic lesions. He received chemotherapy, but he died at 22 years old. Here you can see the presacral mass of the patient who died with the pelvic lesion. Here you can see the family tree. Our patient, his daughter, his son, and his nephew. Other members of the family also were affected, so they had a genetic study that diagnosed Currarino syndrome. Our patient decided not to operate on himself because he presented middle constipation and not anymore fecal incontinence. So he was very happy because of that. But in 2014, he had this MRI, and the presacral mass has grown until 6 centimeters. It has a bilobulated component, and some spinal lesions were found, but he was diagnosed with vertebral hamartomas in his country. He was recommended to have once a year an MRI. He presented slowly but progressive constipation, prostatitis episodes, and occasionally gluteal pressure. In 2022, the mass has grown until 12 centimeters. A positron emission tomography was done, and a 7 centimeter hepatic mass suggestive of malignancy was found. In addition to suggestive malignancy of the presacral mass and the lumbar spinal lesions. Here you can see the tomography of the hepatic mass. A colonoscopy was done that was normal, and tumor markers were normal. A left hepatectomy was done, and the pathology reported a neuroendocrine tumor metastasis. You can see the studies that were done from pathologists, and this mass has a very slow growing. A somatostatin receptor PET was done, and captation was found in pancreas, kidney, the presacral mass, left iliac lymph node, and multiple bone lesions. A committee tumor specialist in neuroendocrine tumor analyzed the case and decided not to operate. Somatostatin injection once a month. Now the patient is asymptomatic, normal labs, and a new PET is scheduled on June. Have you ever seen this tumor? No. Oh, 3 people, 3 persons, yes. Well, those are the articles I found. There are 16 cases. Those were 17 and 18. And somatostatin, octeotride, and 177 lutetio are the systemic treatment, and patients with meds are asymptomatic and alive. This treatment stops the progression of the disease. Thank you.
Thank you, Dr. Maria Sornosa. I think from this presentation, I personally have learned a lot because I have not seen that before. But again, this just emphasizes the importance of long-term follow-up. And I think you must publish this soon because it's important that everyone that treats patients with Currarino syndrome is aware of that, so we can follow our patients and detect and treat appropriately if this happens. So it's very important that you publish this as soon as possible. Does anybody have any question? I think this is a phenomenal presentation. Do you want to comment?
Yes, I also learned from your presentation, and the two publications that you presented, I did not have a chance to read the age of the patients. I have the impression that all of them were adults. Am I right? In other words, the malignancy has not been present in children. So this emphasizes the importance of resecting the presacral mass. Some people say, well, I have patients that had a little presacral mass, and they said, well, it doesn't bother me. I take laxatives and that's okay. And now, based on your presentation and the previous publications, we can say that that is unacceptable. The masses must be resected because they have a tendency to become malignant. So this is something that everybody should know. And if you publish this in the international literature, which I think you should, the conclusion must be that all presacral masses must be resected as early as possible, because, and I don't know the ages of the other patients, that you have to find out what's the earliest case in which it become malignant. Very good presentation.
Thank you.
Dr. De La Torre, do you want to comment?
No, just to congratulate Maria. Thank you, Maria.
Thank you.
Perfect. Thank you so much. And we look forward to see this in a published manuscript very soon, because it's very important. So I'm going to present the next case. Can you see my screen?
Yes.
Perfect. Let me just. So this is a newborn female with absent left radius, normal sacrum, normal echocardiogram that was diagnosed with a rectovestibular fistula as soon as she was born. Because she was born in our hospital, she was not fed, so she was scheduled for a primary repair on the next day. So here is just to show you that she has a normal sacrum. The sacral ratio AP was 0.74 and lateral was 1. She had a right hydronephrosis and the left kidney was normal. She had a low-lying conus. So if you look here, this is L2, L3, L4 was where it was ending. And it's normal when it's in L2. So during vaginoscopy, we were unable to see the cervix. So in that case, if you were in that scenario, what would you do? Cancel the procedure or proceed with the surgery, or I don't know. Please vote. And let's see the answers. Very divided audience. So the majority said cancel the procedure. So since I was the one, I decided to cancel the procedure. The patient with a vestibular fistula, she can stool. It's not an urgent procedure. We just scheduled for a newborn primary repair because she was born in our hospital and she has not been fed yet. But we did that assuming it was a vestibular fistula with a normal vagina, because in the physical exam, we had the impression that there was a vagina. At the moment that the anatomy is not what I have predicted, I prefer to pause, stop, and study the patient. It's better to prepare the family for possible findings than to do all the surgery and tell the family, I did a PSARP, I didn't find a vagina, I reconstructed the vagina, there is no uterus, your child cannot have a baby. So it's a lot of information. You really have to have parents on board and plan correctly for the surgery. So I decided to cancel the procedure. So since I canceled the procedure, imagine that you had canceled the procedure, what study would you order? A pelvic CT, a pelvic MRI, a pelvic ultrasound, or you don't know? Please vote. And let's see the answers. Pelvic MRI. The pelvic MRI is the best one to try to find internal genitalia. Remembering that the earlier you do, the higher the chance of seeing, because the patient still has the hormonal influence of the mother. Because the Müllerian structures in baby is very tiny, so sometimes it's not easy to see it. So in this case, we ordered a pelvic MRI, specifically looking for a uterus. And here you can see what looks like a normal uterus. Here you can see the cervix, and this is the bladder. So with that, we saw that the patient had a good uterus, and we didn't see any upper vagina dilated. That would give us a hint that the patient had an obstructed vagina. So the patient, sorry, I cannot read. The patient came back, she was discharged from the hospital, and then she came back to the hospital with urosepsis. So what study would you like to order once she has recovered from this infectious episode? No need for further study, avoiding cystogram, a kidney ultrasound, or I don't know. Everybody can vote. And let's see the answer. Most people said avoiding cystogram. Very good. The number one cause of urinary tract infections in patients with anorectal malformation is vesico-urethral reflux. So you can see that this patient has a bilateral vesico-urethral reflux.
Grade 3.
Yes. So here is the patient now in prone position. We then knew that the patient had the uterus, no suspicions for obstructed upper vagina because we didn't see any dilation. So here you can see with this mosquito, I am inside the vestibular fistula. Here is the external appearance of the vagina, and here is the urethra. So here we open posterior sagittally. We identify the posterior lateral walls. The posterior rectal wall, we dissected the lateral walls, and then we're going to go into the most delicate portion, that is this anterior separation of the rectal wall from the posterior vaginal wall. And here you can see her vagina, and her vagina, when she's a little older, we were able to measure, it measured 5 centimeters, which is a normal length for a baby. Her cervix still looked a little abnormal, but at this point, with a 5 centimeters vagina, we felt we didn't have to do anything.
Beautiful picture, beautiful picture.
Good. So we dissected the rectum. We had an intact vaginal wall, intact rectal wall, and then we reconstruct the perineal body in the anoplasty.
Wow.
And that's the end of the case. Wow, Dr. Pena is giving me thumbs up. That rarely happens. Okay, any questions about this case? Do you want to comment?
Yes. I think finally Dr. Bishop is learning how to repair a rectovestibular fistula.
No, but I think the reason why I wanted to bring this case, it's just to emphasize there is no urgency in operating on a newborn. So if you find something different than what you were expecting, it's better to cancel the procedure. It's better to truly prepare the family for all the possibilities. Those are sensitive discussions for first-time parents. You don't want to embark into a big operation full of surprise and then have to break up news that sometimes are not well taken by parents. So the only reason why I brought this was just to emphasize the importance of being cautious and really preparing parents. The more information you have, the better it is. So there's a question, do you perform vaginoscopy routinely? Sorry, the question moved up, let me see. Routinely in girls with anorectal malformation. I don't do that for vestibular fistula or perineal fistula. We do it routinely. And for a long time, I have said, if you have a very good exam, you are safe. But in this case, the exam gave me assurance, and then I was not completely reassured with the vaginoscopy. And we have seen cases in which the external appearance looks like a vagina, but then it's blind. So if you have the capability to do vaginoscopy, that would be my recommendation, do in all patients. Dr. De La Torre, do you want to comment?
Thank you.
Do you want to comment?
Yeah, I don't remember exactly the incidence of double uterus in patients with the vestibular and perineal.
5%.
I think it was
5%.
but for vestibular, it was like 12%, I think, and perineal like 5%. But if you don't make the diagnosis of a double uterus and that patient grows up and then become pregnant, it's going to be a complicated. The family is going to be unaware of the risk of having pregnancy. They must be aware of the fact that the patient has two uterus. So when the time comes, they should go to a specialized center to deliver the baby.
Any other questions? So I think if you have the device, do it, because it's 5 minutes, and then at least you are reassured of what you saw and what you should expect. This is a patient, for example, because her cervix still looked abnormal, we're gonna follow her very close. And what that means, when she develops breast buds and starts signs of puberty, axillary hair, pubic hair, we're gonna start doing ultrasounds to make sure that when menstruation comes, she's draining well. The question is, if this case, there was an absent vagina or absent uterus. So when I canceled the procedure, I got further studies so I could plan for the surgery. If I confirmed that she was a case of absent vagina or absent distal vagina, I would have reconstructed at the time of the posterior sagittal anorectoplasty. When you separate the rectum from the vagina, that's the best exposure that you will ever have to reconstruct this patient. So we believe that patients with anorectal malformation, they should have the gynecological reconstruction at the same time as the repair of the anorectal malformation. It's different in cases of MRKH without anorectal malformation, that the family will only find out later in life, and that it's an isolated condition. There are other treatments like dilation. In this case, after we separate the rectum from the vagina, that tissue, it's very fibrotic. It's going to be very hard to be able to successfully dilate. So we think that's the time to repair and reconstruct the vagina. And I'm going to present, if there are no other questions, I'm going to present the next case. Perfect. I hope you can see my screen. So this is a 6-year-old male patient born with an anorectal malformation, tetrachord, single kidney, short sacrum, suffering from rectal prolapse and fecal incontinence. The patient has been clean in the underwear with daily rectal enemas.
It was repaired.
Yes, the anorectal malformation was repaired. So here is the abdominal x-ray. So you can see that there is a very short sacrum. So if we did the sacral ratio would be for sure less than 0.4. And you can see that the patient is doing enemas and the rectum is clean, the left colon is clean. We just see stool here in the right colon. And you can see this is not our patient primarily because there are staples here and we don't use staples to close the colostomy. So the patient underwent a Malone procedure. So this is just to show you how we do the V incision in the belly button. The tip of this triangular flap is the deepest point of the belly button. So you just imagine a triangle. And here is the final aspect when we reconstruct the umbilicus and we try to make it as invisible as possible. And here's the rectal prolapse. The patient is now in prone position. So the prolapse is a little more inside. And it looks to be more prominent in the left side than in the right side. But you have to be very careful about deciding when to do just half side or full size. So in this case, we decided to do full. So we have multiple 5/0 silk stitches at the mucocutaneous junction, and you can see this, how mobile this distal rectum is, and this is the amount that the family described that it prolapsed. So we dissected this much, and then we reconstruct in 2 layers. And that's the final aspect. So the question for you is, do you do bowel preparation when doing a Malone procedure? So for us, bowel preparation means NG tube, go lightly. Everybody can vote and let's see the answer. So it's a mixed audience. So in our case, when we know that there is an appendix, if we are just doing a Malone procedure, we don't do bowel preparation. Now, if you're unsure if the patient has an appendix or not, you better do a bowel preparation.
Why?
Because if we are going to have to do a neo-Malone, we do a colonic flap. So we have to open the colon, place many sutures, and then we don't want huge amount of stool in our field. Now, do you do a bowel preparation when you're doing a rectal prolapse procedure? Everybody can vote. And the majority said yes. So when we do a rectal prolapse procedure, we do full bowel preparation and we keep the patient 7 days NPO on TPN because a complication, a dehiscence, would mean a colostomy in this patient. So that's why we are very conservative, and it's very important to explain that to the family. And the other thing we have to tell them is when to operate on the rectal prolapse. We only offer operation if it's interfering with the patient's quality of life, meaning that it's bleeding, it's painful, produces a lot of mucus, it's constantly outside. That's when we will offer a rectal prolapse repair. A minor prolapse, we just continue to observe because you must remember that patients with poor prognosis for bowel control that had a repaired anorectal malformations, they will always have a tendency to have a prolapse. So we have to be careful on offering that, but we always do full bowel preparation. The next question, do you recommend anal dilation after a rectal prolapse? Everybody can vote. And let's see the answer. Very interesting. The majority not recommending anal dilation. Well, if you have a huge anus, you may be cautioned and not offer anal dilation. But in this case, in which after I cut the suture, the anus is inverted and I have mainly skin, I'm gonna ask the family to do anal dilations because I have seen cases in which it closes, even in cases of poor prognosis. So you really need to follow your patient to be sure that it's not narrowing. The anal dilation in a case like the one that I just showed you, it's very easy because the anus has adequate size already. So it's just a calibration to assure that the healing process will not close the anus. So if you decide not to do it, just bring the patient every month and take a look because there's some cases it does close. So now I'm going to show you a different patient. This is a 32 years old male patient born and operated due to a rectal prosthetic fistula, now with a right side rectal prolapse. So here you can see, and in this case, you can see that it's truly just one side. The other side looks very good. So we repaired one side only. And here is the final aspect. So the question for you, do you need bowel preparation when doing half side rectal prolapse? Everybody can vote. Let's see the answer. So the majority said yes, some people say no. When you do a half side rectal prolapse, the chances of dehiscence and needing a colostomy, I would say is close to zero because there's no way, because half of the rectum is perfectly attached, there's no way that this rectum will retract. If the area that you repair has a dehiscence, it will be very uncomfortable for the patient, but it will not result in a colostomy opening. So some people do it without bowel preparation. I prefer to do with bowel preparation because once I put the sutures, my 5 silk stitches, that's when I realize if this is truly a good case to only do half, or I can see that the other side will need to also be repaired. What happens is sometimes we do one side, then the other side becomes prolapse. So I prefer to come prepared to do full circumference. So because of that, all my patients come with bowel preparation. Now, do you need anal dilation after a half side rectal prolapse? Let's see the answers. Very good. That's the advantage. If you do half side, you have less chance of complications and you don't need anal dilations, but it's not something that we can truly choose. I think it depends on the anatomy of the patient. This was a patient that I was able to do just half side, but we have to be very careful because sometimes we do half side, then the other side looks awful. So the patient will not be happy with entering an operation with one side good and one side bad. You fix the bad and now the good looks worse. So you have to be very careful when selecting to do just half side rectal prolapse. Do you want to comment?
During my practice, I was always very conservative because I was so afraid of having a patient with a dehiscence. And also because I like to work in a very clean and surgical field. And that's why I was very liberal and prepared the bowel of most of my patients. And I enjoyed that. So, but it's up to you. But and some surgeons like to take risks, you know, and in order to say, well, I do everything without bowel preparation and my patient and I'm doing very well. Well, you are doing very well, but if you have one complication, you will never forget that because it's a very very sad, particularly because you know that that was preventable. And that's why I was very, very conservative.
Dr. De La Torre, do you want to comment?
No. I love the case. Thank you.
So any questions from the audience? Let me see, there are a few.
There are some questions for Dr. Peña
Okay, what are the
about the
questions?
follow-up of the patient that Maria presented. I didn't want to answer.
Uh-huh. Where is it?
It is, if you go to Q&A, and there is one that is unanswered, it says,
Answer. How
this
much
patient was
workup?
operated by Professor Peña for redo PSARP with a presacral mass excision in 1995. It was at 8:22 a.m. How long does your unit follow up PSARP post-op? Do you see it?
Yes. So we follow our patients forever, but you
Yes.
can.
Until I die.
Yeah, that's a very big discussion, including with our hospital, because I always say we don't discharge our patients. I think in a year, I probably discharge one patient and the patient that I discharge is the patient that comes to me in clinic with a possible anorectal malformation. I examine, the patient doesn't have anorectal malformation, doesn't have constipation. That's the only patient that it's going to be discharged from my clinic. We follow our patients always and forever. So if the patient is doing well, once a year, we'll follow the patient. We don't discharge. We're working on having a good transition of care program. We have it already for urology. For colorectal, we're working. We still don't have it, so I still see all patients in clinic. Luis see all patients in clinic. We don't discharge them. So I haven't seen this question, so I'm going to go over all of them. How much workup do we need to do before surgery? Our center does not have advanced colon manometry, and access to anorectal manometry is limited. So I see that Dr. De La Torre already answered. We don't use manometry for our patients. What we do is contrast enema and bowel management. We manage the constipation, and that's it. We don't use anal manometry. Do you want to comment?
Yeah. Many years ago, I was doing rectal manometry in many of my patients, and very soon I realized that the rectal manometry was not giving me any valid, important information. When we do a study in a patient, a laboratory study or a X-ray study or manometric study, you expect an answer that will help you to decide what to do. And the rectal manometry, for me, is a totally unreliable study and useless. I understand that perhaps people that is listening to this and is watching this, some people makes a living out of rectal manometry, and lately they are doing colonic manometry. When the colonic manometry appeared, I had great expectations that with the colonic manometry, we would be able to tell us which parts of the colon are not working, which parts of the colon are working, so we will have a guideline to decide what to resect and what not to resect. It turned out that the colonic manometry, as far as I'm concerned, doesn't help at all. And again, a lot of doctors are making a living of that and making a very good living from that, but I don't believe in that.
So now I'm going to look at the chat for questions. In case you find a vaginal septum in routine vaginoscopy, when do you recommend surgery for this? So if it's a case of anorectal malformation and we see a longitudinal vaginal septum, that's the most common one, we resect during the PSARP. You have very good exposure. We have very thin malleables that we put. We put a traction suture and we resect with the Bovie. Most of them are so thin that you don't need to put any sutures. Let me see what other questions. Case number 3 was done without stoma. Yes, the rectovestibular fistula, she was done without stoma. So if a patient is going to be discharged from the NICU with an anorectal malformation, I personally teach the moms how to pass an 8 French feeding tube and inject 5 mL of saline every day. That's enough for the patient to safely stool every day. Most of these patients are either on breast milk or just formula, so it's very easy to digest. So they don't need anything else. And I don't do dilations because I feel dilations are already stressful for parents, and dilating a tiny hole that sometimes it's even hard to find. There's no point in making that fistula normal size if we're going to have to move it and dilate again. So I don't do dilations preoperatively. Sometimes if you want, you can do just a stimulation with a number 7 Hager just to help with stooling. I prefer to inject 5 mL of saline, and that's usually enough. I think I answered all the questions. Let me see. I think so. So thank you everybody for joining. Today we had pediatric surgeons from Mexico, Spain, Slovakia, Ukraine, Yemen, Chile, Canada, Iraq, Italy, Switzerland, Bangladesh, Malawi, Czech Republic, Uganda, Zambia, Philippines, Tunisia, Guatemala, and United States. I hope I didn't miss anyone. And we look forward to see you on May 25th. So thank you very much. Bye-bye and have a great weekend.